Hello? Can you hear me? Good morning, ladies and gentlemen. I think we should start. We're slightly late. Welcome to this lunchtime symposium on update on myocardial protection. The symposium has been kindly sponsored by Dr. Franz Kohler-Kemi from Germany and Vitanova PC from Kazakhstan. Thank you all for coming to listen to this. My name is Dr. David Chambers. I'm from London, the UK. It's been my privilege and pleasure to introduce the session, and we have three eminent surgeons who will give their talks on the use of primarily custodial in various aspects of cardiac surgery. So I'd like to start the session with a brief introduction before we go into the surgical aspects of myocardial protection. So this is just a flyer that you've seen already, and that's me. I'm at St. Thomas's Hospital in London. So what are the optimal conditions for cardiac surgery? Well, ideally, the surgeons require a bloodless field for good visualization and a non-beating heart for operative ease. And these conditions can most easily be achieved by inducing global ischemia. But we all know that ischemia causes myocardial injury. And at the onset of severe ischemia, a number of events occur within the myocardium. And all these events, in a brief period of time, cause a reversible injury. But at some period, some unknown period, during the ischemic period, there is a further onset of events that cause irreversible damage. And this leads to cell death and necrosis. So whilst ischemia is convenient for the surgeon, it's damaging for the heart. So protection of the myocardium is required to delay the onset of irreversible injury during elective ischemia. Many techniques have been tried, but the most successful has been cardioplegia. So what is cardioplegia? Cardioplegia is the elective, rapid, and reversible paralysis or arrest of the heart during cardiac surgery that involves cardiopulmonary bypass. And I just want to emphasize this slightly more, because if we look at this graph that shows percentage recovery of the myocardium with increasing durations of ischemia, you get this S-shaped curve, and at some point there is no recovery of the heart. All cardioplegia does is move this graph to the right. And so you still get the same shape of graph, and you can extend the safe ischemic duration, but ultimately, if you have a long period of ischemia, there will be no recovery. So in patients, we want to work at the top of this graph where there is very little injury. And so it's important that we have timely reperfusion. It's essential to have timely reperfusion. Let's look at some historical developments of myocardial protection. In the early 50s, open heart surgery with cardiopulmonary bypass was developed. And within a very short period of time, in 1955, Melrose in the UK introduced the concept of cardioplegia by elevated potassium-based arrest. Unfortunately, he used very high concentrations of potassium and citrate, and this led to myocardial injury in the myocardium, and the cardioplegia, the blood-based cardioplegia at that time, was abandoned. Now, around 1960s, in Germany, Brett Schneider introduced the concept of sodium-poor, calcium-depleted arrest. This became the HDK solution, or custodial. Unfortunately, or maybe not unfortunately, but Brett Schneider published his work in the German literature. So this is a publication from 1964, and another one from 1967 where he's reporting the protective effects of HDK solution. But this was not seen by the English-speaking surgeons. And so between 1960 and 1975, mainly in the UK and the USA, protection, if you like, it wasn't really protection, but they used normothermic or hypothermic ischemic arrest. It wasn't until the mid-70s that Brett Schneider started publishing in English. But by that time, there had been a revival of elevated potassium-based arrest in the laboratory and in clinical practice at St. Thomas's Hospital, where the cold crystalloid potassium-based cardioplegia was introduced. In 1979, Buckberg in the USA introduced cold blood potassium-based cardioplegia. In 1991, warm blood potassium-based cardioplegia was introduced. And so, in the majority of countries that conduct cardiac surgery, cold, tepid, or warm blood potassium-based cardioplegia predominates. So, despite HDK solution being used for more than 50 years, potassium arrest has been the predominant means of myocardial protection during cardiac surgery since the mid-1970s, so around 40 years now. Cardioplegia can be formulated in two types. Extracellular type solutions, where it mimics the ionic concentrations of the extracellular fluid. And examples of this are the St. Thomas's Hospital solution, the Buckberg solution. Or intracellular type solutions, where the ionic concentrations mimic the intracellular concentrations. And examples of these are the HDK solution or UW solution. These types of solution tend to be used for long-term preservation in heart transplantation, but obviously custodial can also be used in normal as a cardioplegic solution. What's the mechanism of cardioplegia? Well, potassium induces a depolarized arrest. And if we look at this graph of resting membrane potential against extracellular potassium concentration, at a normal extracellular potassium concentration of 4 millimolar, there is a resting membrane potential of about minus 85 millivolts. If you increase the extracellular potassium concentration, the resting membrane potential becomes more depolarized. In other words, it becomes more positive. And at around 10 millimolar potassium, you reach the threshold potential for sodium channel inactivation. So arrest is induced. If you go too far, too high a potassium, you reach the threshold potential for calcium channel activation. This leads to calcium influx, and this is bad news for the myocardium. So there is this window of ideal potassium concentration. The St. Thomas's Hospital solution contains 16 millimolar potassium, and it sits pretty much in the middle of this window of protection. So depolarized arrest with potassium has limitations. Ischemia and hypothermia inhibit sodium-potassium ATPase. This leads to activation of the sodium window current, activation of the sodium-hydrogen exchanger, and this causes sodium loading. Sodium loading causes reversal of the sodium-calcium exchanger and activation of the calcium window current, which leads to calcium loading. And calcium loading causes maintained energy utilization, contracture, reperfusion injury, and cell death. So what's the alternative? Well, we can induce a polarized arrest. Polarized arrest maintains the myocardial cell membrane potential at or near the resting membrane potential. This should lead to balanced ionic gradients, few channels or pumps being activated, and reduced energy utilization, which should lead to improved cardioprotection from a cellular perspective. Examples of polarizing arrest are a new solution that we've been developing in my lab, but also the HTK solution, custodial. Custodial is a crystalloid solution. It can be used for cardioplegia and for heart transplantation. And the formulation or the composition of the solution is given in this slide. You can see that the sodium concentration is 15 millimolar. The calcium concentration is very low, 0.02 millimolar. It does have potassium, 10 millimolar, so there will be some depolarization induced by this potassium. It has a histidine buffer. It has tryptophan, which is an amino acid, and alpha-ketoglutarate, which is a component of the citric acid cycle. Now, if we look at this diagram of excitation-contraction coupling and targets for arrest, low sodium targets the fast sodium channels and inactivates the fast sodium channel and prevents the sodium spike of the action potential. The almost zero calcium will inhibit the L-type calcium channels and prevent calcium-induced calcium release and therefore contracture. This will lead to a polarized arrest at between minus 65 and minus 70 millivolts. Now, this sodium and calcium ratio in HDK solution is extremely important because the low calcium levels could induce a calcium paradox. But if you have a low sodium level as well, then you avoid this. Now, Professor Preuser from Bonn has explained this in this slide, which I've borrowed from him. He said there is a law of nature that states the ratio of the square of the intracellular sodium to the square of the extracellular sodium is a constant. And similarly, the intracellular calcium concentration, the ratio of the intracellular calcium concentration to the extracellular calcium concentration is constant, the same constant. So you can, from this data, you can work out if you reduce the sodium concentration, what the calcium concentration should be. So if we have a sodium concentration of 150 millimolar and we reduce it to 15 millimolar, so a 1 in 10 reduction, or 1/10 reduction, then we can put the required calcium concentration into this equation, and we can see that it should be 0.015 millimolar. And that's exactly what we have. So there is a reduction of the calcium concentration by 1/100. And this is exactly what we see in the custodial. 15 millimolar sodium equates to 0.02 millimolar calcium. And this reduction in the sodium and the calcium will avoid the calcium paradox. So custodial comes in different sizes of bags, which is convenient for the surgeon. It should be infused at a temperature of 5 to 8 degrees centigrade. And the infusion duration should be between 6 and 8 minutes. So quite a long infusion duration. And the infusion volume is 1 ml per min per gram of estimated heart weight. So if we have an estimated heart weight of 250 grams times 6 to 8 minutes times 1 ml per minute, this equates to 1.5 to 2 liters of solution to achieve homogeneous equilibration. Custodial is a single-dose cardioplegic solution, and that can be administered one dose for global ischemic periods of between 2 hours and 2.5 hours. So it's convenient for minimally invasive and pediatric cardiac surgery as it avoids reinfusions. And this is compared with potassium-based cardioplegia, which has to be reinfused every 20 to 30 minutes, and obviously interrupts the surgical process. So custodial is potentially much more convenient for the surgeon. So that's just my basic introduction to the myocardial protection. Our next speaker is Dr. Alexei Popov from Moscow, and he's going to talk about his experience of using custodial in pediatric surgery.
Good day, dear colleagues. We've been asked to come up with our results of morphological studies of kids' myocardium performed with comparison of various methods of myocardial protection with custodial solution. I realize we've got professionals in the corresponding field, but still let me shortly remind you what happens in the myocardium during global ischemia and reperfusion with no due protection. So during the first seconds of aortic cross clamp, it's so-called latent period. Aerobic metabolism still takes place in mitochondrials of myocardium thanks to auxiliary oxygen supply. As soon as oxygen pool reaches the critical level equal to partial pressure below 5 millimeters, the myocardial starts to consume energy produced by means of anaerobic glycolysis. Within 4 to 5 minutes, its viral period, the macroaggregated phosphates pool exhaustion takes place. Resorption of phosphocreatinine level to 3 micromoles per gram in the left ventricle tissue is accompanied by functional up to asystole and ultrastructural dysfunction followed by exhaustion of ATP. Reperfusion and reoxygenation lead to restoring of pre-ischemic myocardial function, provided the ATP level in the muscle of the left ventricle exceeds 2 micromole to gram. After reaching this critical level, contraction of myofibrillus happens, provoked by failure of penetration ability in cell membranes as a result of metabolic changes and increase in calcium supply into cardiomyocytes. So according to Jennings, criteria of irreversible heart damage are low level of high energy phosphates, total suppression of anaerobic glycolysis, degradation of over 75% of adenine nucleotides. And Hottenrott describes structural shifts of this stage as clarification of mitochondrial matrix, disappearance of glycogen granules, destruction of cell membranes, and death of the cell. On the slide you can see disappearance of glycogen granules and mitochondrial swell with matrix clarification. The patient died. In our research for estimation of myocardial damage levels, we actually used the last criteria mentioned. Scales for estimation of mitochondrial state and quantity of glycogen were worked out, which you can see on the slide. Ischemic damage involves both myocyte and vessel endothelium. Cell swell results in dysfunction of release of relaxin and contracting factors. It plays an important part in increase of resistance of coronary vessels during a perfusion, and along with extravascular capillary compression and adhesion of hemocyte comprises no reflow phenomenon. The most frequent answer to uncontrolled blood supply through coronal vessels after ceasing global myocardial ischemia is stunning. This phenomenon characterized by reversible post-ischemic systole-dystolic myocardial dysfunction based by fully restored blood flow given on myocardial necrosis, and is the base of low cardiac output syndrome after cardiac surgery. When myocard is maximally damaged, it gives way to tearing. Myofibrillus detected by contractions. Free radicals play an enormous part in damage of myocardial during reperfusion. The final stage of the process, initiated by aortic occlusion, supported by ongoing ischemia and getting more intense due to uncontrolled reperfusion with no proper protection, are myocardial necrosis. Markers of myocyte necrosis are significant increase in level of creatine kinase, lactate dehydrogenase, transaminase, and ultrastructural changes detected during the submicroscopy. In my report, I'd like to tell you about our two researches on comparison of cardioplegia on children aged below 1 year old. All morphological myocardial research was performed with help of biopsy needles. Official representatives of children gave their written consent to comply with Russian legislation. The first research involved two groups of patients, all of whom were below 1 year old, and who had a correction of heart defect. The characteristic of the group you can see on the slide. Absolute majority of the patient had mitochondrial index above 4 points, which shows atypical for this age condition of mitochondria, which a dense matrix according to the electronic microscopy found in cardiomyocytes with incomplete fibrogenesis. Throughout the whole period of surgery, only one patient had the index of mitochondria below 4, same as 2 once during reperfusion. Interestingly, it was those patients with the mitochondrial index below 4 during the reperfusion who had a decrease in level of glycogen in cardiomyocytes during the surgery itself. This first ever discovered dependency certainly requires further testing on more material. In case it proves, it might turn out important for further exploration of peculiarities of cardiomyocytes, ischemic damage develop on cardiomyocytes with various level of mitochondrial differentiation newborns with congenital heart disease have. Results of the research carried out demonstrate that patients of the second group didn't have statistically significant changes in average indexes of cardiomyocytes alter structure throughout cardiac surgery with cross-clamp period from 43 to 91 minutes. This is the patient from the second group too. And those from the first group had statistically a significant decrease in mitochondrial indexes throughout cardiac surgery with cross-clamp period from 22 to 63 minutes. The dynamics of mitochondrial index during heart disease correction is presented on the slide. As for, here it is. As for another attribute of ischemic damage, exhaustion of glycogen pool, neither of the group demonstrated its rapid reduction. Dynamics of glycogen content in cardiomyocytes throughout the radical surgery is also presented on the slide. And the results obtained show efficiency of both methods used for myocardial protection from intrasurgical ischemia on younger patients with congenital heart disease. Within this being said, myocardial ultrastructure analysis carried out talks of the fact that in spite of being injected only once, custodial solution provides for due myocardial protection for the whole aortic cross-clamp period from 60 to 90 minutes, whereas usage of St. Thomas Hospital solution for cross-clamp period from 30 to 40 minutes provoked the first symptoms of reperfusional damage of cardiomyocytes. I must say that clinical data obtained during the research, along with biochemical analysis, corresponded with the data obtained during the morphological research. As concerned the second research, Here, the regular biochemical analysis was supported by creatine phosphokinazole level dynamics analysis. Among other clinical data, post-surgical catecholamine index was estimated as well. Sadly, it was impossible to perform a great number of biopsy material studying, but on the top of myocardial electronic microscopy, histochemical research of right atrium biopsies were performed. Only patients below the age of 1 year old with congenital heart disease took part in the research. During the research, the following interesting discoveries were made by us. The volume of inotropic support on finishing the bypass and dynamics of its decrease during the first post-surgical days with the use of custodial and an experimental solution were comparable. That is mean index reflecting the total need of for adrenomimetics don't have statistically significant difference in both cases. The same tendency was noticed in the markers of myocardial necrosis dynamics after surgery. Both solutions were equally efficient at protecting myocard which was proved by cytological and histological research. Biopsy material taken 30 minutes after the start of reperfusion showed the condition of intracellular structures didn't differ radically from the initial. The present microphotographs show that the content of glycogen and condensed state of mitochondrials in cardiomyocytes with the use of custodial solution doesn't differ substantially. The upper peak shows the biopsy obtained before aortic cross clamp, and the bottom one obtained after 59 minutes of cardioplegia and 30 minutes of reperfusion. You can see on the upper peak the nucleus with relatively smooth nucleolem, lateral myofibrillus, T-system canals, mitochondria, and glycogen granules. During the optical microscopy of the right atrium myocardium, high glycogen content in the initial biopsy materials and its local minor decrease after cardioplegia were detected. All in all, we can conclude that based on the data obtained during morphological study of biopsies and well as coming from clinical and biochemical data obtained during research, the use of custodial solution on patients aged below 1 with complex heart disease is safe. Thank you for the attention.
Thank you very much for that interesting talk. Are there any questions from the audience at this stage before we have a panel discussion? Any burning questions? Not at the moment? Okay, so we'll wait. Thank you very much. So our next speaker is Professor Bruno Podesser from Vienna, and he will talk to us about myocardial protection in minimal invasive aortic surgery.
Okay. Just prepare some water. First of all, I would like to thank Dr. Köhler-Chemie for allowing us to come to Astana. It's a fascinating place, and not only this conference center, but the whole city is astonishing, beautiful, and we are very happy to be here. So my topic will be myocardial protection in minimal invasive aortic surgery, and during the first part of my talk, I will mainly talk about minimal invasive approaches to replace the aortic valve. In the second part, I will then focus on how we do it in terms of myocardial protection. I have to disclose that I am a consultant for Edward Life Science and LivaNova, and I have an experimental research grant with Köhler-Chemie. So during Cold War, life was pretty easy. And I don't have to tell you that here it was clear there are good and bad guys. I'm not sure who of the two guys is the good and who is the bad one. And I made this comparison because aortic valve replacement until 2002 was also pretty simple. If you were younger than 65 years old, you probably received in most places in the world a mechanical valve. If you are older than 65 years, you would have received a biological valve. But then in 2002, Alain Cribier did the first-in-man percutaneous aortic valve replacement, and suddenly things changed. Because now it was not the surgeon to do the operation, but you could do this via a catheter transfemoral. And today we have a plethora of different transcatheter aortic valves, TAVIs. We can do them transapical, transfemoral, or transaortal. And we have a different spectrum of, or a wide spectrum of different valves that can be used. By this development, also the surgeons had to question their position. Are we too invasive? And we know that, of course, from other surgical approaches, gallbladder operations and so on. The less invasive you are, the quicker our patients might recover. So the concept of full medium sternotomy was and is questioned. It is the gold standard, of course, and it is, as a pro, we all know, we can expose the entire heart. But as a contra, one can say the incidence of mobile sternum is, of course, higher. We are compromising the respiratory mechanics, and definitely cosmetically, it is not a very attractive way to enter the chest. Alternatives have been developed, and one is the anterior right thoracotomy, where you can expose normally only the ascending aorta. You have stability of the chest, and of course the respiratory mechanics are better. The pain is considered to be similar. Cosmetics are, of course, better. What is definitely demanding is a conversion. If you have to go and convert these patients, it is a demanding procedure, and you have to be quick not to endanger your patient. The contra is, of course, that it is only a partial exposure of the heart. You probably have to go via the groin vessels, the iliac vessels, to put on your patient on cardiopulmonary bypass, and you definitely should do a preoperative CT scan to know exactly how the position of your aorta is. A third alternative is the upper hemisternotomy or mini-sternotomy. The pros are you only see the ascending aorta, but you have again a stability of the chest, you have better respiratory mechanics, pain, and cosmetics. A conversion is pretty simple. As a possible contra, however, at least some surgeons use groin access of the vessels, and I personally try to not to touch the groin if not necessary. All that was paralleled by a second development. This started in 2007, and this is the concept of sutureless or rapid deployment valves. This is, in fact, a historical concept from the 60s, when the McGovern-Cromie sutureless valves were the first developed, and you can still see them in very rare patients, of course. I've seen just one patient with this valve, but in the Edwards Museum, for example, you can see it. The revival was in 2007, and today we have two, in fact we had three, the ATS Enable, but this is actually not on the market anymore, but the Sorin Percival and the Intuiti Edwards or the Intuiti Elite are two rapid deployment or sutureless valves that are on the market. And they combine the best of the conventional and the TAVIs. What are the differences between sutureless and rapid deployment valves? The sutureless are true sutureless. That means they are pericardial valves, and they have just three sliding sutures that you remove after the operation. They are from nitinol, and they are folded on ice. In contrast, the Edwards Intuiti is a rapid deployment valve that has three stitches at the very lowest level of the valve, at the nadir, and they are also pericardial. They are similar to the Carpentier-Edwards Magna valve on top of an expandable steel frame that you can see probably at the bottom. If this pointer is working, I'm not sure. No. The pointer is not working, but it is on the bottom of the valve. So, in 2017, therefore, we have to consider, when we ask a patient, or when a patient asks us, what is the best valve for me? You would have to decide which type are you giving him, a mechanical, a pericardial, or a sutureless, or a TAVI valve. You would have to make a decision whether you insert this valve surgically or interventionally via the apex. And you would have to make a decision where you open the chest, make a partial opening of the sternum, or a lateral thoracotomy. How to start when you start your small incision program? This is another picture where the Intuiti valve is already in place. I put up some tricks that I would like to share with you. I would start with a mid-sized patient with good ejection fraction. Important is place the defi patches externally. I would start rather with the fourth, then the third intercostal space, so fourth or fifth at the beginning if it is a large patient. Dissect the sternum with an oscillating saw and use bone wax. Insert a small retractor so that you have enough space, and then prepare the pericardium and try not to open the pleura. Then heparise the patient. Use a Seldinger technique for the aortic cannula. This helps you and makes it easier for you to go, and it spares room. Dissect the vena cava superior and insert the venous cannula via the cava superior to the cava inferior. You can even do that in large patients, but take your time. Start cardiopulmonary bypass and place a vent either in the upper lung vein or later through the ascending aorta. Place cardioplegia line in the ascending aorta and then do the aortic cross clamp and use cold antegrade cardioplegia. I will elaborate on our concept a little bit later. Then do your standard aortotomy and start CO2 inflation. Decalcify, but do not disrupt the annulus. This is very important whenever you use one of those expandable valves. Otherwise, you have a problem. Use stay sutures at the commissures to push up a little bit. And then size and wash. And then place the 3 stitches at the nadir so that you either can use the expandable or the sutureless or the deployment valve. You see, with all those steps, you don't want to care about another second cardioplegia. That's why I emphasize that is an important thing. Lower the valve and fix it with a tourniquet. Double check the position of the valve in the annulus. Inflate the balloon, remove the holders and balloons, fix the 3 sutures, or take them out if it is a sutureless valve. And then check the position of the 2 ostia. And then you're almost there. De-air it before you open the aortic cross clamp. Don't forget to place your wires and the drain, because you will not be able to reach the heart after the clamp is open. And then go off bypass and double check your sutures. You don't want the bleeding after such an operation. Pitfalls are bad exposure of the valve. So please check the stay sutures. Do not play with ischemic time. Cardioplegia is vital. Don't forget to place the pacing wires and the chest drain before opening. Bleeding. If you have a bleeding, convert, because you will lose the confidence of your team if you play with the life of your patient. Don't forget to use CO2 and external DeFi patches. They make your life easier. And remain calm and speak with your team when you do something different. Our cardioplegic regimen for that is quite simple. We try to look into literature, but there is hardly any literature on minimal invasive aortic valve surgery and cardioplegia. Custodial is mainly referred to mitral surgery, and this is going to be presented by Professor Sabo in the next talk. The latest article is from 2017, and it's also focusing on, although right mini thoracotomy, on mitral aortics, on mitral surgery. But what they compared were custodial versus blood cardioplegia based on St. Thomas number 2, and they did not see any differences in outcome. I just placed one figure of this publication here, that is the troponin T, and there was no difference postoperatively. So what we use is, we use custodial at about 4 degrees Celsius. We lower the body temperature to 32 to 34 degrees. As long as the heart is beating, we perfuse the heart with a pressure of 80 to 100 millimeters of mercury and infuse custodial at this pressure. When the heart stops, you lower the perfusion pressure to 60 to 70 millimeters of mercury. In total, we have a cardioplegia time of 7 to 9 minutes. Then you're done. In average, we give 20 milliliters per kilogram of cardioplegia, kilogram body weight. It's a single shot. It's safe for at least, and we've heard that from Dr. Chambers, 120 minutes. And yes, we do use ultrafiltration if necessary because of the volume. Between 2012 and 15, we operated about 100 intuitive valves and about 35 Sorin valves with an average age of 75 years. And you see this is the distribution of the valve size, so it's about an average of a 23 or a large in the Percival Sorin group on the right side. Perioperatively, the majority of our patients were in NYHA classes on the left side, in NYHA classes 2 or 3. And if you look on the percentage of Euroscore, the majority had a Euroscore of 6 and 7. Operative characteristics, about 50% of the patient on the left side of the slide had an isolated aortic valve, and 43% had CABGs plus aortic valve. On the right side, you see that out of the isolated aortics, about 1/3 was done with a minimal invasive upper hemistenotomy. If you look at the function on the left side, this is Vmax preoperatively. So about 73 50% of our patients had a high degree Vmax, so highly stenosed aortic valve. And postoperatively, upper level is immediately postoperatively and low as 1 year afterwards. 83, 84% had physiologic valve function. The 30-day mortality was 5% on the left side, and the 1 year mortality was about 16%. Out of those, the majority, or 10% had a cardiac reason, and 6% had other reasons to die. And this is the outcome in terms of a Kaplan-Meier survival curve, which would give you at a 50 months, a little bit lower than 80%, it is 78%, no difference between male and female. Now, if we summarize, to do a tailored aortic valve replacement in a patient older than 60 years, at this stage, in 2007, would you use a standard pericardial valve, a rapid deployment valve or sutureless valve, and the third on the right, a TAVI? My answer would be, for an isolated aortic valve with a low Euro score, I would either use a pericardial valve standard or a sutureless valve. For a high Euro score, I would give those patients a TAVI. If we have a reoperation, I would either use the TAVI or the rapid deployment valve. They can be done easily, and in this analysis, it's a nice operation. For combined surgery, of course, I would either use a standard pericardial valve or a rapid deployment valve. How would be my approach? Whenever an isolated valve, aortic valve, I would go for an hemi or a hemistenotomy, or of course a transapical approach. And for combined surgery remains full stenotomy the only choice. And how would that, regarding the cardioplegia, I would say safe cardioplegic regimen is crucial for these procedures. Custodiol allows you to work without a reinfusion. You have a safe arrest for at least 120 minutes, no difference in enzyme release, and acceptable early and midterm survival results. Thank you very much.
Thank you, Bruno. Very interesting talk. Is there any questions from the audience at this stage? Yes, please. Do we have a microphone?
You have a loud voice.
Please shout.
Should I? Yeah, I think it's a very good question. In those operations, I have to say that I presented, we had no patient with longer than 120. If we have a period of more than 120 minutes, I would go for an additional full cardioplegia. That means another 1.5 liter for sure. And the latest our cardiotechnician would kick me is with 150 minutes. But they would insist after 120 minutes that I have to take care of it. I hope this is an answer.
Okay.
There's another question.
Oh, okay. Yes, please. Can you use the microphone? Just coming.
Thank you. What kind of temperature your cardioplegia solution?
So we use the cardioplegia. Our cardiotechnicians tell me it is 4 degrees. So it would be between 4 and 6 degrees Celsius.
Thanks.
Okay, thank you very much. Okay.
Now with the micro.
Yes. if you need selective perfusion, cardioplegia, selective, and you have the patient with the left coronary
stenosis.
Left coronary type of angiography, and you have a little right and big left. How you will work when you do selective? You do 1 liter on some another technique.
It's getting difficult, I think, because whenever the beauty about custodial single shot is that you normally don't have to go selective, because you just infuse it into the root and then you dissect the aorta. If you have to go selectively, and this is a small right, I probably would just give maybe 500 milliliters into the right. That's probably the maximum. I did a lot of minimal invasive aortics where we used blood cardioplasia, and with blood cardioplasia you have to reinfuse after 20 minutes. So then, if you have a small right, I would not even give any cardioplasia to the right. I would just induce and then the reinfusion just to the left. But as I said, I feel a lot more comfortable with one-shot custodial at the beginning when you don't have to decide selective perfusion or not.
Yes, please.
It was a nice presentation. Thank you for sharing with us. I was thinking about your indication about what valve you were going to put. And I see the reoperation, you just go for TAVI. Maybe we should open the subject on this, because we have different type of reoperation, even our aortic valve, previous mechanical. But the point is this not a little bit too far from the current guidelines where they say this should be inoperable? I understand the high risk, that is like a gray area, but reoperation, just all of them there, maybe yes, maybe no?
If I can go back my slide, it says either from, this is a recommendation how I do it, and my personal approach is, if it is a complex high-risk patient, one should consider valve-in-valve, for example with a TAVI, or what I just pointed out before, or use a rapid deployment valve, because you have this calcified annulus. When you remove your old biological valve, you can put in the new one, and the nice about if we talk about the Edwards, for example, the Intuiti, as it has this high stale frame, it would cover all the area where you take out the valve and where you might even dissect it, the area under the pledgets, yeah, of the first operation. So in this last slide, or in the slide before the last, I said for reoperations, I personally try to use either a TAVI or a rapid deployment valve. So I'm not using absolutely TAVIs. So maybe this is a misunderstanding.
Thank you, Bruno. I think we should move on. The next speaker is Professor Gabor Szabo, and he's going to talk to us about myocardial protection during minimal invasive mitral valve surgery.
Thank you, Chairman, ladies and gentlemen. First of all, I would like to thank for the organizers for the invitation. Yeah, my topic would be myocardial protection in minimally invasive mitral valve surgery. And as I prepared my talk, I tried to focus on hard data in this topic. And as also Bruno mentioned, actually there's very few evidence about myocardial protection in minimally invasive surgery. Nevertheless, I try to gather some some thoughts about it. Cardiac surgery changes during the last 2 decades substantially, and if we want to summarize what are the changes moving direction minimally invasive. And if you want to be honest, these changes might, in most of the cases, driven by the development in cardiology. And cardiology put us under pressure to make more minimal invasive techniques, because the main argumentation in concurrent approach is that the cardiology approach is less invasive. In fact, the last heaven mitral valve surgery became also a field of concurrence with the introducement of the MitraClip procedure, and in fact in Heidelberg we have in the meantime more MitraClip implantation than mitral valve surgeries. And even heart failure, which was a very long time of a classical surgical approach with new devices, small devices, we use mini thoracoscopy approaches for this kind of surgery. Anyway, it seems that today this is a golden age of minimal invasive cardiac surgery, and there's a high demand of the patients who are really very well educated due to internet, Google, whatsoever, what they want. And they want to have minimal invasive approaches, nevertheless with the same safety as a conventional cardiac surgery and the main durability. And I think we are in the challenge to provide these techniques, but also in the aspects of safety and durability. And therefore, because going to direction on mitral valve surgery, let me give some thoughts about the first field of minimal invasive surgery, and this was the surgery of bypass surgery 20 years ago. And the argumentation was off-pump surgery, either done by minimal invasive approach or full sternotomy approach, is less invasive because of the avoidance of myocardial ischemia reperfusion. And what happened even in the very early years, the publication of a New England Journal of Medicine stated, it was about 100 patients per group, that even if off-pump surgery was safe and caused less damage, there was a difference in terms of graft patency, even in a very short term. And unfortunately, these results were also confirmed a couple of years later in large-scale clinical trials. One of them is the most famous, the Ruby trial, which showed that the graft patency of arterial and venous grafts is worse in the case of off-pump surgery. And a novel meta-analysis showed of about 20 studies and over 100,000 patients that this worse quality of off-pump surgery can be translated to the worse survival after 5 years. So this meta-analysis showed a significantly reduced long-term survival. So what we learn, even if we are working minimally invasively, cardiac surgery must be durable. And the second, the cardiac protection might be an issue, because if we use a beating heart technique, maybe our quality is not so good as used with the cardioplegia, so we have to make much more attention for cardiac protection. So what is the situation, especially in valve surgery? In that case, we need to have cardiac protection because we operate an open heart. What are the advantages? We have decreased pain in a lot of studies. It is cosmetically most attractive. In in a lot of studies, decreased length of stay in ICU or in a hospital was documented. Nevertheless, and this is an important point, this is regular is more demanding for the cardiac surgeon, which in turn results in a longer ischemic times in most of the studies, and in some cases impaired cardiac function, high costs. So the question is whether the advantages and the disadvantages are the most important factors. And here I will go in the direction of mitral valve surgery, a quite new study which looked at, I mean, money rules. Study from last year from the Annals of Thoracic Surgery in Downs, a multi-center study in different US hospitals. And what is important, what they show, that there are two factors. One factor, the increased cardiopulmonary bypass time and cross-clamp times, which are quite substantial in case of mitral surgery, because mitral surgery is complex, or around 2 hours or 1.5 hours, one side, and longer operating room times, and on the other hand, less blood cell perfusion, somewhat shorter. I mean, this is a couple of hours, not a huge difference, but somewhat shorter ICU stay and hospital stay, which in turn results in a somewhat more cost effectiveness in mitral valve minimal invasive surgery. The question is whether we have optimized myocardial protection strategies. This may even lead to superior outcome in mitral valve surgery. So if we have a good approach here, at least in mitral valve surgery, minimal invasive approach can or they will become the gold standard. So myocardial protection is a question of religion. As David told us in his nice introduction, the most of the cardioplegics uses blood or crystal based on potassium arrest. And the basic principles of both types of cardioplegia, the arrest itself, which reduces myocardial oxygen demand substantially, even in normothermic conditions. And if temperature is cold, we have actually a very low energy consumption, which provides a good myocardial protection for a substantial time, about 30 minutes. So it's most of the studies which was made to compare blood and crystalloid solutions showed no differences, and until now there's no evidence either blood or crystalloid cardioplegia, and in that case I'm speaking about potassium-based cardioplegia, would be superior even in terms of clinical outcomes on myocardial answers such as. Is there a clinical evidence for mitral surgery? Indeed, we have one prospective randomized study that was a mixed cohort of minimal invasive and complex the open cases where cold blood cardioplegia was compared with custodial. This is a US study, and what we see here in terms of myocardial enzymes, we have no differences over the first days and first hours and days in terms of CKMB and troponin T, and also the correlation between cross-clamp time and myocardial injury is almost the same in custodial and blood cardioplegia. A huge difference between the two cardioplegic concepts, that custodial was used as a single shot, and as properly used, blood cardioplegia required repetitive shots after 20 minutes ischemic time. Well, how looks at a minimal invasive and open minimal invasive surgery? There's a couple of descriptive studies. What I showed is actually the subgroup analysis of the previously showed study custodial versus swarm cardioplegia. And what we see here, we had, and this is impressive results, we had lower need for blood transfusions, a better stroke rate, lower hospital readmission days, readmission rate, and in the custodial group. And the other outcomes categories were similar. So this paper concluded in the USA that custodial is safe and cost-effective when compared with traditional blood cardioplegia. We have Austrian experiments here, minimal invasive and conservative mitral valve operation were compared, and both groups used custodial. So the primary aim of the study was not to compare cardioplegia, but to compare minimal invasive or conservative approaches, but using the most convenient cardioplegia based on the US study. And what we see in this study, we have lower need for blood perfusions, and shorter ICU stay, hospital stay, and otherwise good outcomes. So the authors concluded that a single dose undergrade custodial offers a status-appropriate and safe myocardial protection in minimal invasive surgery, and makes minimal invasive surgery a better alternative for mitral interventions. Well, there is a more than a rather descriptive how to do paper from Germany. They report about 1,400 patients undergoing open mitral surgery and only in a very few percent minimal invasive, and they made a kind of comparison in outcome with very robust clinical parameters such as mortality or ICU state without any closer parameters on myocardial damage, and this was rather than a historic comparison. Nevertheless, they concluded in descriptive paper that the custodial was easy to use as a single-shot cardioplegia, and without any data, they also suggest that that custodial have a better endothelial protection. But it was very important in this paper. This paper was the base for their minimal invasive program, which became the worldwide leading minimal invasive program in the world, because on the base on the open cases and what we experienced with custodial, they had a cardioplegia. We allowed them to longer ischemic times in the minimal invasive approach. We have also Italian experience, and here what we see is also custodial was used on the base of the previous experiments, and what is very important also here, we have substantial differences in cross-clamp times in the minimal invasive approach. Here in the Italian, almost 40% higher cross-clamp times, but what they see in this study that they had no differences between myocardial enzymes and clinical outcomes. So again, in this paper, the myocardial protection was not the primary goal of the study, but on the base of a custodial-based cardioplegia, they could achieve the same safety, durability as in a conservative approach. And last but not least, I do not want to left you without any numbers. So there is actually the only study which investigated, Bruno mentioned it very short, the use of blood cardioplegia versus another cardioplegia, custodial, in the setting of right thoracotomy. And as you see, the majority of the patients had a kind of mitral valve operation from the right thoracotomy approach associated with or without tricuspidal valve surgery. Nevertheless, there's a few percentage of additional operations from the right thoracotomy approach, such as closure of ASD or a myxoma, which from the perspective of myocardial protection can be handled as a mitral valve operation or a minimal invasive operation as well. And what we're seeing, these are the patients, about as a 44, 46 patients in two groups, and there was some differences in terms which surgery was performed, but as I mentioned, even there is some differences in the surgeries in terms of myocardial protection and anticipated cross-clamp time. The two groups were homogeneous. And here we have the most important results describing myocardial injury enzymes, and what we see regardless at what time directly of the operation, 8 hours, is around the peak of troponin or CKMB, also around the peak of troponin, and even after 1 day, so within the first 24 hours, there was no significant differences between the groups, and other parameters such as myocardial arrhythmias or cardiac arrhythmias or low cardiac output syndrome was similar. This is the same for ICU stay, mechanical ventilation. So in general, both cardioplegia approach was in their cohort similar. So what we can see, or what we can conclude from the data what we have to date, we have similar outcomes in minimal invasive and open mitral surgery. And we have also no clear evidence about the superiority of any cardioplegic strategy. But if you're looking at the literature and most of the experiences, most of the centers use, especially for this approach, custodial. Even if you use other cardioplegia for aortic surgery, minimally invasive aortic or bypass surgery, because it's very convenient due to the single shot use, and in mitral surgery, especially minimal invasive, you have expected long cross-clamp times. This is safe, this is also cost effective, especially if you compare with Bachberg. And the non-inferiority in that context, and also to my opinion, is enough to make it as a primary solution for mitral valve surgery, because the other convenience factors are just better than another cardioplegia. But I think prospective cardioprotection studies are really necessary to make a final judgment which myocardial protection study, protection strategy is better for the particular minimal invasive approaches to be better than sometimes the cardiologists. Thank you very much.
Okay, so do we have any, perhaps we could invite the other speakers up to the podium here, and if we have any other speakers, if we have any other questions for any of the speakers. Any questions at all for the speakers? So maybe I have a question. So is it, I've seen in the literature, some literature, that some people use lower volumes of custodial than are recommended. If they do that, would this reduce the duration of protection? Or does it make no difference? And would you recommend that that is a strategy to use? Because My understanding is that custodial is quite expensive, and so people are trying to cut down the cost. So what do you think? Is that on?
Okay, yeah. So it's a very good question whether to use a cardioplegic solution as prescribed or not. And without going details, we have a very hard experience according to this question in a clinical study which is running, a prospective multicenter clinical trial, where one of the centers do not attach the protocol what they should have. So we generated a huge amount of data, what will happen. But I think that is what I show in the basic principles of the cardioplegia. If you have a short cross-run time of 30 minutes, 40 minutes, such as in aortic valve surgery and bypass surgery, I mean, alone the cold temperature will provide you most probably a safe ischemic time. And even if you don't use custodial as you should, most probably doesn't happen anything. There's a huge difference if you make minimally invasive mitral surgery, where you go very quickly beyond 100 minutes. And in that time, I can promise you, this also in our experience in the beginning, that surgeons who do not attach strictly to the prescriptions, they have at least higher enzyme rates and higher catecholamine need and higher ICU stay. It's very hard to publish such data, because of the approach of the surgeons.
I just can underline what you said. It is important to train the perfusionist and the surgeon in terms of patience. If you give the heart this 7 to 8 minutes at this perfusion pressures that we mentioned during our talks, it allows custodial to go homogeneously into the tissue. Being an intracellular solution, it needs to be there. Otherwise, we will have, as Gabo just said, serious ischemic areas in a hypertrophic myocardium, for example, that are difficult to reach. And then the consequences are, of course, either intraoperative infarction, mini-infarction, higher uses of catecholamines.
Okay. Any other questions? Yes, please. In the audience?
I think it's a very good question. The question was ejection fraction of 20%. I think it is all a question what is the surgery you want to do. If you are doing a complex mitral repair plus bypass surgery because of ischemic mitral regurg, type 3 and so on, you might expect a long operation, so probably custodial is a very good idea. If you're just replacing, or you're just doing a double bypass or triple bypass, you're probably fine with blood cardioplasia, and I would in this case recommend Buckenberg cardioplasia.
Any other questions? Please, yeah. Oh, you talk to him afterwards, okay. Okay, so we need to translate the questions before we can ask them. Any other questions? I think we're coming to the end of the session, so perhaps I ought to summarize. And it seems to me that from the evidence that we've seen, both in children and in adults, there basically is no real difference between using custodial or blood-based potassium cardioplegia. This is the message that's coming out, but importantly, if you have a long ischemic or a proposed potential long ischemic duration, then custodial might represent the cardioplegia of choice because it's much more convenient for the surgeon to do an initial, okay, it's a long time to do it initially, but then you don't have to touch the heart after that or interfere with the surgery. So that it would seem to me that custodial may be the solution to use in those circumstances, and the benefit to the surgeon is probably more than the benefit to the patient. Both solutions are equivalent. So perhaps that's the take-home message from this session. I'd like to thank everyone that came to the session. I'd like to thank the organizers, Dr. Kola Kemi, Vitanova, and I'd like to thank our speakers very much. Thank you.